Well, hello, and thanks so much for joining me today for episode 3 of season 3 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. Since this pandemic began last year, there's been a truly tragic rise in the number of homeless individuals around the nation. Policymakers have been pitching ideas right and left for how to fix it. Here in California, our Governor Newsom announced this week $12 billion to address the problem. Our Mayor, Eric Garcetti, pledged another $1 billion. Most of these proposals have focused on housing, both here in California and nationwide, but not everyone is bought into the idea that this is exactly the right solution. Many advocates who work on the front lines of the homeless crisis have argued that housing, homelessness, and health are inextricably linked. And unless we address the root causes, in many cases, mental health and substance use issues, but in some cases, other medical issues that get in the way of individuals earning money, living safely and healthy in houses, providing housing on its own is not going to be sufficient. So today, I'm going to talk to my brother, Dr. Stephen Hochman, who is a frontline primary care doctor at the JWCH Health Clinic in Skid Row, the largest homeless encampment in the nation here in Los Angeles. And he's going to provide his perspective on this issue based on his interactions with his patients who lack housing. It's a really interesting discussion and hits on some key policy themes that have been coming up a lot in the news. So please do stick around for it. If you do find today's episode engaging, please search and subscribe to The Healthy Skeptic wherever you listen to podcasts. Search for The Healthy Skeptic MD on YouTube. Pass it along to friends and family, and do consider leaving a review if you have a chance. So before we jump into our interview today with Stephen, as always, let's do a rundown of the health news for the week. And the first big news item that I want to touch on is the authorization by the FDA of the COVID-19 vaccine in children 12 to 15. In fact, we have a whole episode in which we discuss COVID in kids and the safety of vaccine in children a couple weeks ago with Dr. Jessica Hochman, a pediatrician, and my wife, so check that one out. But in brief, what Jessica told us in that episode is that the data on the vaccine in the 12 to 15 age group is very encouraging with respect to safety, but the numbers are small. So given how well kids do with COVID-19, the benefit to risk ratio for an individual child is pretty small. But what you do need to keep in mind is that there are very significant benefits from a public health perspective to the larger community if kids in that age group do get the vaccine. So we do hope that parents will take this into consideration when deciding whether or not to vaccinate their child. So the next health item I want to touch on is the lead article in this week's New England Journal of Medicine, which looks at the issue of ear tubes in children. And actually, we had an entire episode also devoted to this topic a few months ago with Dr. Nina Shapiro, a pediatric ENT specialist at UCLA. And what Dr. Shapiro told us in that episode is that while ear tubes absolutely have benefits, parents should not rush into a decision of putting them in kids because they are certainly not a be-all and end-all for preventing recurrent infections. And this is exactly what the New England Journal article this week found. So it looked at kids who had had 3 or more episodes over a 6-month period of ear infections, and it found that placement of tubes did not actually prevent further recurrence of these compared to not placing a tube. So important information for parents to consider who have children with recurrent episodes of ear infections. So the last news item I want to mention is a study in JAMA Internal Medicine that looked at the use of osteopathic manipulations as might be used by a chiropractor for adults with lower back pain. So it was a very interesting study. It compared real osteopathic manipulations versus sham procedures. They found for adults with lower back pain that the benefits of the real procedure were small, but they were so small, in fact, that the authors concluded it was unclear if these benefits were meaningful. Now, the one insight I will provide here is that patients with lower back pain can be absolutely miserably uncomfortable. And if trying out an osteopathic manipulation can help you buy time to let your body heal, it can help delay or even prevent a surgery entirely, which would be a very good thing. But certainly this study did not suggest an objective, clear, significant benefit to these manipulations. So something to consider. That's it for the news summary of the week. Let's jump into our interview with Dr. Stephen Hochman. Well, welcome back to the Healthy Skeptic MD podcast, Dr. Stephen Hochman.
Hi, it's great to be here. Third time's the charm. I saw you had a couple of repeat guests, and I had to get on a third time so I can stay atop the leaderboard.
You are indeed the first third-time guest on the Healthy Skeptic MD.
Awesome. Well, thank you. It's a pleasure to be here.
Many of my listeners may have been familiar, heard your background, but just for a reminder for those who aren't, Stephen is a primary care doctor on Skid Row in Los Angeles, taking care of homeless populations. For those not in Los Angeles, can you just remind us what is Skid Row?
Yeah, so Skid Row is an area of downtown Los Angeles where there's a significant collection of homeless individuals living, people experiencing homelessness. Um, it's not designated officially by the city, but it's certainly become sort of a place where people go when they don't have another place to go. It's important to remember that there's a lot of homelessness that leaves Skid Row in Los Angeles that lives in other places, but it's the single largest collection, I believe, in Los Angeles. And people have called it the greatest man-made disaster on earth. They've called it hell on earth. It's a really stark area where people experiencing homelessness are very exposed, and the condition that they're in is pretty impressive and for not the right reasons. And I work in a clinic right in the heart of that area where we take care of the healthcare services, mental health, and substance abuse services for these patients.
And there's a incredible number of people who live on Skid Row. Do you know the estimated population on Skid Row?
I think Skid Row, it's in the several thousands. I think we're up to about 8,000 to 10,000 people are there. I don't know. It's a population that's very transient. So at any given time, it might vary, but there's a lot of people in a few square block radius.
And tragically, during this pandemic, the number of homeless population in Los Angeles, although we don't have any official numbers, seemingly has increased dramatically. Has that also been seen on Skid Row? Have you noticed that the population there is increasing?
I think it's interesting. A lot of the patients that I work with on Skid Row are the chronically unhoused, people who are not sort of bouncing in and out of homelessness, but have unfortunately found a very stable not home there. And so I haven't seen a huge number of patients myself who are now without a roof over their heads simply because of the COVID pandemic, although there certainly are some. And I can tell you the challenges we face on Skid Row have been really intensified by the pandemic because people who used to be able to move in and out of shelters or things like that are now being subjected to COVID tests and issues like that make it a lot more complicated. In the greater Los Angeles area, I think income loss due to the pandemic has become a real issue for many families and people who are now experiencing homelessness. Although I do need to be honest, in my day-to-day practice, that's not typically the patient population I see too much of.
So today we're going to talk about the issue of mental health and substance use challenges for the homeless population. And it gets down to how do we help solve this really major crisis that's affecting every aspect of the city here in Los Angeles and around the nation. And so that's what we're going to talk about today. How do you as a frontline doctor caring for these populations take care of these issues? So maybe you can begin with what percentage of your patients on Skid Row suffer from mental health and substance use?
So again, I think it's really important to understand where I work. On Skid Row, we have a chronically homeless population, and truth be told, I think that nearly 100% of the patients I see suffer from substance use disorders, mental health disorders, or a combination of the two. Now, we do have some data on this nationwide. I think the last big survey was done, in the mid 2010s, 2015, 2016, showing that in any given year, there's about 1.5 million people who experience at least a night of homelessness. About 500 to 600,000 who are on the streets any given night in the United States. And of these, about a quarter suffer from what's defined as serious mental illness being mental illness that affects daily functioning. There's a symptom that allows you to not function in a daily capacity. And then about a third of patients who experience substance use disorders. Now, if you sort of drill into that data, if you take people who are chronically homeless, those numbers go up a lot. We're talking more like 50 to 60% of patients experiencing homelessness chronically have mental health or substance use issues. And if you include any history of mental health or substance abuse issues, that number goes up to almost 80%. So I think there are some people who bounce in and out of homelessness based on losing a job, or in this case, like we just talked about, the pandemic, who may not be experiencing these challenges, but there is definitely a majority of patients experiencing chronic homelessness who have suffered from these conditions, if not actively, at some point in their lives.
And when you talk about mental health issues, are you talking about depression, anxiety, bipolar, schizophrenia? What are you referring to here?
So this is actually something that my practice has changed a lot since I've been working on Skid Row. I think a couple of years ago, I would have described the patients I treat by their diagnoses, and um, the name of a diagnosis is important, but I think much more important is to understand the symptoms I treat. I treat a lot of severe paranoid delusions. I treat a lot of audiovisual hallucinations that affect people's ability to be in public. I certainly do treat a large amount of severe depressive episodes. I also see a lot of sort of the cluster B personality traits. These are the people who often get described as very dramatic, with splitting, a lot of confrontation in their lives. And so the diagnoses I do see the most of are probably, schizophrenia, uh, major depression, bipolar disorder, personality disorders, also a great deal of PTSD. But like I said, I've noticed from working with my fellow colleagues who are psychiatrists and just in practice, it's much more useful for me to talk to a patient about what symptoms are bothering you. You know, it's the hearing the voices, or it's the paranoia that someone's trying to get you, is much more useful for me clinically on a day-to-day basis than naming it, although I do think that naming it is important.
Well, that's so interesting. We doctors like to put everything in boxes. This is schizophrenia, this is bipolar, but you're right. There's probably a lot of overlap, and people don't easily always fit into one of those boxes.
Some people get really upset at being labeled one thing or another, versus if we make the conversation about what symptoms prevent you from feeling good, what symptoms prevent you from living the life you want to live, people, my patients tend to be a lot more receptive to that.
Well, I think that's a great point. And at a much smaller scale in my primary care practice, I see that too. People may not want to be labeled as being having major depression, but they will certainly talk about feeling down and low energy and those symptoms. And that's a much better way to start a conversation there. And then in terms of the substance use issue, what drugs are your patients using? What recreational drugs?
I think the number one thing I actually see are stimulants. Stimulant use disorder is so prevalent among my population. So stimulants are crystal meth, cocaine, crack cocaine, um, uh, ADHD meds like Adderall, which can be either prescribed or purchased illicitly. So all those sort of fall into the category of stimulant use disorder. Many of them use them recreationally achieve that particular high. Many of them on my panel, though, use them for survival. If you fall asleep on the street unprotected, you will get robbed or worse, beaten up or potentially killed. And so people use stimulants to keep themselves awake throughout nights. Um, Certainly, opiates, that's your heroin, your fentanyl, and then similar to the stimulants, you have your prescribed things like oxycodones or hydrocodones, Percocets, Norcos, as well as those pills that are pressed on the streets. And so between stimulants and opiates, I think that probably takes care of 80 to 90% of what I see.
There's a lot of discussion about the prescription opioid epidemic we're facing as a country. Do you see a lot of that, or is it more street drugs that you see?
Well, it's interesting. I see a lot of street drugs. So certainly the answer to your question is more street drugs is what I see, but there's a just truly sad amount of that started as prescription drugs. Some of my most heartbreaking patients are patients who had a workplace or other injury, got on oxycodone, um, you know, you know, did not get weaned off it rapidly, and then the oxycodone prescription dried up because it was no longer appropriate from the doctor that they were seeing at that time, and then they'll turn to street oxycodone or worse, heroin or fentanyl.
There's something of a debate in the homeless care community about to what extent are mental health and substance use sort of linked to the housing challenges. So on one extreme, you have people who sort of have the belief that we just really need to focus on housing supply. If we build the houses, offer the houses, it will solve the problem. And then on the other extreme, there are those who argue that homelessness is a mental health issue by definition. It's substance use, it's mental health that explains it all. And if we could just fix that and solve it, maybe the answer is somewhere in between. But where do you fall on that spectrum?
I think my answer is I'm gonna stay firmly in between. But because if you do not have a house to go to, if tonight you're going to be just finding a park bench or riding the buses through the city all night, uh, you can't focus on your diabetes or your blood pressure, or, it's sort of preposterous for me to be giving you an order to get a mammogram or a colon cancer test if you don't know where you're going to be sleeping tonight. You just have such a more pressing concern that housing first advocates, that makes perfect sense to me. You cannot place someone in a situation with nowhere to go. But that having been said, asking someone experiencing severe substance use disorder, severe mental health issues, and homelessness to sort of go at it on their own just because they have a roof over their head, that's sort of not a recipe for success either. And I think just an illustrative example, and not to spend too much time in anecdotes, but I met a patient who came in, a daily heroin user. We were treating him for that, and we got him housed. And interestingly, in the past, he had an issue with an infection in his stomach, a complication of a heroin injection that got infected, and he actually had a colostomy. So this patient, we got into a house, and we weren't able to fully address all of the substance use and mental health issues, as we almost never are right off the bat. And we got him home health, and home health was a nurse who visited him a couple times a week to help him with his colostomy. And I started receiving the orders to co-sign from the home health nurse. And at first they said, patient is here, patient is doing well, but within just a couple days to a couple of weeks, they were, patient wasn't home when I got there, didn't answer his phone. Or worse, patient was clearly intoxicated when we arrived and was unable to comply with services. And then it got really bad. Patient has been throwing his feces from his colostomy bag all over the walls and things like that. And eventually, he lost his housing because the landlord who worked there was unable to sort of manage and cope with him. And I certainly feel both sides of the story. I don't want to bury I don't want to make it seem like the big bad landlord just wants to make money and kick people out. It was a landlord running a building full of people who needed the housing, and this one person was really affecting the housing of all the others, and it just wasn't a working system. And so, I think that's an illustrative example of how, if you are not able to adequately control the substance abuse and the mental health issues, you can find yourself putting someone in a house that rapidly does not work out. You really just can't have one without the other. Housing first is a fantastic slogan, but it's a slogan. And once we get past just the slogan and we talk about what we really need, I think we're all saying the same thing. I think we're all saying people need to both be in houses and getting the supportive care services. And it's a little bit chicken egg, which comes first, but I think they really need to come at the same time.
Well, I'm going to ask you in a few minutes about a judge's order here in Los Angeles that gets at the heart of that issue. He ordered that everyone be offered housing, and there's a big debate about whether that's the right approach or not. So we're going to come back to that very important issue. But before we get to that, let's talk about, how do you, as a frontline doctor for homeless patients, how do you start to think about treating substance use and mental health?
Yeah, so if we oversimplify, but I mean this is a pretty reasonable one, and we break it down into sort of, there's the behavioral interventions, that's the counseling and the supportive services, is sort of one arm of the treatment, and medications are the second arm of the treatment. And I think I'll start with a little bit of my personal bias. Medications work. Medications have changed our lives for the better. They save lives. We know people don't die of infections as much anymore. We have treatments for cancer, all these things. But medications, in my view, are always sort of the last option. We need to try to support the patient with safe and effective counseling first. And the main reason I think that is because I think, one, we overestimate the benefit that medicines give. Medicines are rarely just a cure-all. You don't just give a pill and the patient magically gets better, even if the pill works. And the second reason is because medications have lots of side effects, and so we're always dealing with upsides and downsides. And so, looking at sort of the social and behavioral and cognitive modes first. we have counseling, and counseling comes in many, many different flavors. So in my practice on a day-to-day basis, I use a technique called motivational interviewing. Motivational interviewing is a counseling technique where you try to find ambivalence in the patient's life. So maybe a patient who's using heroin and they're kind of like, I like using heroin, I like getting high, it feels good, but I do know that it's keeping me from getting a good job. I do know that I've lost family relationships, and the goal of the clinician is to sort of use interviewing techniques that guide the patient to resolve that ambivalence. So how can we push you towards wanting to sort of maybe go more towards an abstinent route than using the drugs. And so I use motivational interviewing all day, every day. Actually, that's pretty much what I do. Many of my colleagues who are formally trained in counseling use other techniques. Cognitive behavioral therapy is one that many people have heard of. It's sort of one of the most popular. Cognitive behavioral therapy seeks to sort of educate patients and help intellectualize the process, helps patients understand, fact and fiction, truths and myths about their current condition, and allows them to then develop coping mechanisms and other skills to help them be more functional with their condition. On the flip side, on the medication side, uh, we have a couple of good medicines for substance use disorders. Many people have heard of methadone. Methadone is a full agonist. Agonist being a medicine that sort of fits in the same receptor the drug normally would and turns that receptor all the way on is what an agonist is. And so people take methadone instead of heroin. It's sort of more of a controlled way to elicit a response from the opiate receptor. We also use antagonists. That's the opposite. That fits in the receptor and blocks any high from being turned on. We use medicines called naltrexone or Vivitrol is another name, a brand name for a long-acting version of it. And patients can get those medicines daily, and they can block the use of a otherwise intoxicating substance. Medicine I use a lot of now is between the two. So like many things in life, probably the middle is really where we want to be. I use a medicine called buprenorphine. That's a partial agonist. And so it fits in that receptor. It turns it on a little bit, but not all the way. Patients on buprenorphine are not in any way high. They're totally functional, but by giving them some of that agonist action, they're able to reduce their. And so there's a whole series of medicines like that for those were all for opiate use disorder. That's heroin, fentanyl, oxycodone, Percocet, those medicines you may have heard of. There's a lot of off-label uses of medicines that help reduce cravings for stimulants. And then obviously for mental health issues, we have a whole cadre of antipsychotics and antidepressant medicines and anti-anxiety medications that we use. Although contingency management can also be as simple as, the counselor I work with for substance use disorders keeps a hot pot of coffee in his office at all times, and if you come in to see him, you can have a cup of coffee and sit with him and chat about what's going on. And so that's sort of a lot of information all at once, but those are the techniques and the general strategies that we use most often for these conditions.
Yeah, well, it sounds like one of the things that your organization, JWCH, provides is that sort of safe space, warm cup of coffee, some meals that will make patients comfortable, come in and just start the conversation. And listening to you talk, it seems like that there are a lot of tools that work. None on its own is a magic bullet, but you certainly have tools at your disposal. But one of the challenges, from what I understand, is the availability and access to these services. You're one person, you're the primary care doctor. What is the availability of these social treatments for your patient population?
So I think there's two parts to that question. The availability is actually pretty good. There are a lot, we have a lot of providers in our clinic who can help provide these services: substance abuse counselors, licensed clinical social workers, other case managers, and things like that. And that's in our clinic. We also have the Department of Mental Health, who has all their own things, a few other third-party mental health treatment places. Now, even with all those people, my view from where I'm sitting, the need exceeds what we have. But we actually have a lot of people that I can refer to. But then there's the practicality of getting it done. And in our modern day healthcare system, we've built in so much complexity to getting things done many times, even when all the pieces are there, they don't come into the right alignment to make it happen for the patient. And so, I can have the idea to refer a patient to a particular social worker for a particular type of counseling, or maybe a particular service. Um, but if that patient has to even leave my office and walk across the street, that's an opportunity for a patient to get lost to follow up. If that patient needs to receive a phone call, they can miss the phone call, or many of my patients don't have phones. Or if we make them an appointment for a certain day, they can lose the piece of paper, or something more life-threatening can come up. They can they can be attacked and not be able to make the appointment. And so many of my patients who are struggling with substance use and mental health issues, it's really hard to navigate the system. Frankly, it's really hard to navigate the system if you've got nothing else going on. But if you've got homelessness, if you're experiencing homelessness and you have some disorganized thinking because of schizophrenia, and you're periodically using crystal meth as a stimulant, it's just really hard to get actually through to where you need to be. And so I think the services are there, though we probably still need more of them. But the services are not really as accessible as we need them to be, and they're not as easy to use. Things that we do with no barriers to starting get the best uptake.
Well, that's such an interesting and important point, and it's that's something we see throughout the healthcare system, is that our system is so complicated. We create barriers for patients and make it so hard to get the things that they need, even if those services are available, even if we do have a supply of them. I just want to specifically ask you about medications. So, many of your patients will have access to taking appropriate mental health and substance use medications, but do they actually do it? And how is their compliance? And if it's not good, what are the barriers that interfere with them taking their medications as they're supposed to?
Yeah, so I think the first question is simple access. We are so fortunate at JWCH in our clinic downtown that we have a pharmacy in our clinic. And so, most of the time, I am able to send a patient in the same building, 50 feet from my office, to the pharmacist where a medicine can be picked up. And I think that having that service right there is really useful. The problem is, many times these medications that we're talking about will not be necessarily covered by insurance off the bat, or they might require paperwork to be covered by insurance. And so I think the first hurdle that we see is, even if it's the same thing. I know many of your listeners might not expect this, but if I have to ask a patient to leave the clinic and come back to pick up their medication tomorrow because paperwork needs to be processed, I would guess I'm going to lose 20 to 30% of my patients right there who just aren't going to come back for that follow-up visit. The second hurdle is keeping your medication. My patients often live in places where they get robbed. People take their medications. We always, my patients and I, it's sort of one of those, you can't cry, so you might as well laugh. Their diabetes medications will be stolen, and we'll say, why in the world would someone steal some metformin? That's not going to help anybody. But the truth is, people get robbed all the time, experiencing homelessness, and people aren't reading the pill bottles to see what they do and don't want to take. They're just taking it all. And so my patients have their medications stolen on a very regular basis. The third thing is just sort of disorganized thought process and thinking. One of the sort of central symptoms of a lot of the mental health and substance use issues I see is very disorganized thinking. And if you are keeping your medicines in all different places and you're spending one night here and one night there, medicines might not get stolen, but they might get misplaced. And so you've got all these sort of built-in hazards to being able to take your medications. And then once we get to that point where I think we've probably lost maybe 40 to 50% of our adherence already there, then we get to the concern of, well, then how much does the patient take the medication? And I think patients take medications that make them feel better. But many of the medicines, especially mental health medicines, take a couple weeks, if not months, to really work. They need to be doses increased and monitored and things like that. And if the patient is taking a pill that they don't feel like is making them better, many of them will stop taking it. Suboxone I mentioned, the buprenorphine medicine I mentioned before for opiate use disorder, that one gets a lot of compliance. It works immediately. You take the medication and you do not crave opiates that day. And so compliance with buprenorphine formulations tends to be very high. However, buprenorphine tends to be something that people really want to steal. It has high street resale value. And so um, adherence for those other set of reasons is an issue with buprenorphine. But um, I would guess that, somewhere around 40 to 50% of my patients are able to take these medicines very regularly without interruptions in their regimens.
Well, you described really a dizzying set of challenges that are going to affect compliance with medications. And, for a typical middle class population, we know medication compliance is far, far from perfect, and there are many barriers. And it just seems like for your population, all those challenges are multiplied by at least an order of magnitude. So for that reason, there's been a lot of interest recently in what are called long-acting injectable medications. These are medications that can be administered directly at the point of care by a clinician, and they will act for several weeks, in some cases even several months. Can you tell us a little bit about these long-acting injectable medications? Are these tools that you ever use to address some of these compliance concerns?
Absolutely. I do think these long-acting injectables hold a lot of promise and certainly have a role. And I think the important thing we need to do as providers is to use them in the right role. So the one I'm going to actually talk about first is a long-acting injectable version of buprenorphine, that medicine we talked about just a minute ago for the treatment of opiate use disorder. So the medicine, the brand name is Sublocade, but it is long-acting injectable buprenorphine, and it's a once-a-month injection rather than taking they come in films, so it's a once-a-month injection rather than taking the film. And I actually think that medicine shows a great deal of promise. There are two concerns I have with long-acting injectable buprenorphine. One is many patients who have a history of substance use, especially injection substance abuse, really just don't want to tolerate any needles in their lives. And I understand that's something that makes sense to me. And so a lot of my patients will turn down the buprenorphine as an injectable for that reason alone. They just say, Doc, I can't do needles. I'm sorry. I see how it would be easier. I see how it might work better. But I can't do needles. The other thing is there's a lot of operant conditioning going on in substance use disorder. It's not just about enjoying the high. Many patients have that daily need, that daily addiction to do something, and some of them gain a lot of comfort by dosing themselves every day with their medication. Some tell me it's just a reminder of the recovery journey they're on. Others tell me that they don't feel the drug in their system if it's injected once a month. And whether it is placebo or whether it is science, it doesn't matter, because the patient's what matter. And if the patient doesn't feel it, it's not going to work for the patient. And then just to jump over onto the long-acting injectable antipsychotic medications, I see some clinics, especially the Los Angeles Department of Mental Health, has started using these more. The biggest challenge of a long-acting injectable antipsychotic is that you need to find the right dose, which means you need to get the patient stable on a daily oral medication for long enough to know what you're doing to safely give the long-acting injectable. And some of our patients aren't actually even able to sort of do that. There's also concern from patients for side effects. You're going to inject this medication into me, an antipsychotic that gives me some side effects, and I'm just not going to be able to get off that ride for a month, or like you said, sometimes 2 or 3 months. And some don't like the idea of it for that reason. However, I will tell you, for a minority of my patients, a handful even, maybe 5 or 10 who I see on a regular basis who do get long-acting injectable antipsychotics on, at doses that they've been titrated to effect, they do really well.
Are there any ethical concerns? What sort of acknowledgement and consent do you need from a patient before giving them a medication that's going to affect them for the next several months?
Well, I mean, I think at the bare bones, you really need to make sure the patient knows what they're getting into. So, informed consent, I think, is a lost art. It's this 2-word phrase that we use a dozen times a day when we're in our trainings. And I'm not sure, we ever really do it the way we're supposed to. But, really making sure a patient understands what is the medicine, why are we getting it? What are the upsides? And then the hardest part, what are the downsides? And really doing that weighing of risks and benefits. I think that long-acting injectables, if done with proper informed consent, we have special consent forms for our long-acting injectables at our clinic. I think, I don't think there are ethical issues. That having been said, then you get to the ethical issue really comes. There are a lot of patients who may not be able to follow that logic. If you're actively schizophrenic and in need of a long-acting injectable antipsychotic, can that person truly receive informed consent?
Yeah, well, it's interesting hearing you talk about it. It seems like there certainly is a lot of promise from these long-acting injectable medications, but again, they're not magic bullets. You do need to do dose titration. You do need to think about these consent issues. What about on the practical side? Are insurance companies, these can be very expensive medications. Are insurance companies covering them?
So that's one place. I criticize insurance companies a lot of times, but this is one time when I have to say I actually think that they've sort of gotten a little bit more on the ball and are going in the right direction. So long-acting injectable buprenorphine is covered without much paperwork or much of a hassle by all the major Medicaid plans that I work with. The long-acting injectable antipsychotics get covered, but there's definitely a lot more paperwork. And typically what happens is the medicine, the process of getting medicines approved can be so complicated that there's a whole specialty pharmacy system where provider, so theoretically me, tells the pharmacy, I want this medication and here's why. Then the pharmacy does all the interfacing with the insurance company, gets the approval, asks me more questions if the insurance has more questions. And then once approved, the pharmacy will send the medication to me to be administered in my clinic. Now, I think that's it's good that we have a system that allows us to get these medications, but that process usually takes a week or two. And as we've talked about a couple times earlier in this discussion, if the patient is in front of me and I let them leave the clinic, maybe I have a 75% chance they're going to come back in a week or two. And so, there's definitely the concern that work is for naught.
Well, this is really helpful in sort of getting some insights on what it is like to manage mental health and substance use issues for homeless patients on the front lines. So, Stephen, I want to close out today with a couple questions about policy. You've talked a lot about the barriers that make it harder than it needs to be to provide the services that these patients need. What policy changes do you think are needed that would make your job easier and, more importantly, would make it easier for homeless patients to get the care they need?
It's about lowering barriers. It should be easy to get an identification card. Obviously, I say that, getting an identification card is important for national security and things like that, and I don't disregard that. But some kind of identification card that allows patients to pick up medications at the pharmacy or qualify for a housing program. Getting an ID should be easy. And actually, I think there was just some California legislation that's working its way through where individual clinics could distribute sort of a Medicaid ID card to a homeless patient right there on the spot, which I think would help a great deal. Getting a cell phone should be easy. Okay. There are phones provided to patients. There are government-sponsored programs, but right now they're very complicated. The government pays, but they're through all these third-party private groups, and all those individual groups are trying to get market share. And so, patients don't know where to go. And if they sign up with one and then lose that phone and try to switch to another, well, the first one doesn't want to lose the business, so they make it hard for the patient to get to the other. So, things like getting IDs, getting phones for communication and appointment reminders, that should be easy. Those are things I think policies that let us just give out those things in clinic would be really useful. I also think that we need to reduce the mountain of paperwork in order to say someone needs to be housed. Right now, in order to get someone into housing, whether it's sort of, there's sort of more urgent, emergent medical housing where I'll see a patient and I'll say, I don't think this patient can fly on the streets. They're going to be in and out of the emergency room every day. And, we need to get them sort of a semi-medical bed versus even just the general housing in Los Angeles, which goes through a system called the coordinated entry system. And I do fill out this, 10-page complicated application for the medical bed, I don't even I thank my social workers. I don't even get into the coordinated entry system and how complicated those interviews are. That's an hour to an hour and a half interview with the patient to answer questionnaires to get it filled out. Point being, to get someone into a house or an apartment or sheltered, it just takes a mountain of paperwork. And really, I think it should just take someone raising their hand and saying this person needs to be housed.
Well, hearing you talk, it just seems like more of these decisions need to be brought to the frontline individuals who take care of these patients and themselves. We need to remove sort of disconnected third-party decisions and give the funding and the decision-making authority to people at the front lines who really know what individuals need. And there's always going to be trade-offs there, but hearing you talk and how challenging it is to get patients the care they need, it seems to me that that's the right way to go about it.
There are some programs that do that. They're really successful. I had a patient, one of great patients, and a program, a case manager who had access to housing and supportive resources. He was, we were talking about this the other day. Found him decompensated heart failure, daily use of crystal meth, living in a drain pipe. And they were able to achieve on a small scale what we're talking about. I mean, they just pulled him up, said, do you want to get out of this drain pipe and come live with us here? And all he had to do was he said yes. He said yes. And that night he was sleeping in one of their beds with supportive services. And now I think we're, 8 or 9 months later, and he is taking his medicines. He looks fantastic. Was just telling me how excited he was to go see the new Mortal Kombat movie with some of his other friends who were now living with him. I mean, it's beautiful to see when the system works. And so we know from these cases that it can work. How do we make it work on a mass scale without the red tape and so functionally? I do believe it's possible.
Well, I think it is great to hear those stories because those don't always come to the forefront. We hear about all the challenges, so it is great to hear how the stories worked. Well, I want to finish with that question I started to ask before about the federal judge here in Los Angeles. It's drawn a lot of attention. There was a judge who said that everybody in Skid Row must be offered housing by October. That doesn't need to be permanent housing. It can be shelters. It can be any form of housing. And there have been opinions on all sides of the spectrum here and everything in between. And, again, it just gets at this question, if you give people housing, is that sufficient to solve the problem? And I would just love to hear your take on this judge's order, whether it's in the right direction.
Well, listen, I think we start with the obvious answer that we sometimes skip. Yes, it's in the right direction. We need to talk about homelessness. We need to find ways to help this incredibly vulnerable population. And so, yes, it's in the right direction. We need to be talking about it. I smile a little bit when I hear the judge's ruling. I offer a house, a shelter to every single patient I see. If I didn't, I wouldn't be doing my job. When a patient comes in and they're living on the street, I offer them work with a social worker to try to get into this coordinated entry system, or maybe a behavioral health bed or something like that. So I am already doing this every day for every patient, but the system is so difficult to navigate, and there's so many barriers where patients can be lost to follow-up that oftentimes we can't finish that system. So I think if the judge's ruling comes with reductions in red tape and bureaucracy that allows us to actually do that, when I say to a patient, do you need help with housing? They say yes, and then we can actually get them into the next stage and moved into a sheltered environment. I think that would be fantastic. But like I said, I think if you're just putting someone with active substance abuse and mental health conditions into a house without the support, that's not going to go very well. So we really do need one to come with the other. And the other thing that I just want to add about the judge's ruling, and this is not saying it's going to happen, but I think we need to be very careful to just, let's get these people off the streets. I mean, right now, for better or for worse, Skid Row is where a lot of the resources are. And I do fear that my patients who are near me and their other resources, if their tents just get cleared off the streets and they just get put somewhere else, you could really make the process worse that way.
The counterpoint I've heard to that is also Skid Row is where the drugs are. So if you break up this gigantic encampment, it actually might create some barriers to people getting drugs.
I think that you are probably right. I think that the truth is, though, that everything in life is a risk benefit. Okay, I talk. This is the example I always give to my patients: is in a few minutes I'm going to go to work and I'm making a decision. I'm going to take a risk of driving on the LA freeways. Put my life at risk for the benefits of going to a job that I like doing, and I accept that risk with that benefit. I completely agree. Skid Row is a place where there are tons of drugs readily available. I mean, when you walk down the street, when I go out at lunch to grab a coffee or something, people try to sell me drugs on the street. They ask me if I want to buy. And many of my patients who are in their recovery will tell me, Doc, can we do a few more telehealth visits instead of telephone visits, instead of in-person visits? Because I'm just worried about putting my sobriety in jeopardy if I go to that place. And so, yes, having a major collection of folks living in one place where a lot of them are using substances of abuse is definitely a downside to having Skid Row there. But I think that the benefit of having the services close by is it probably exceeds that. And look, now here I am. It sounds like I'm defending Skid Row. Skid Row is a terrible thing that never should have existed, and we should get rid of it as soon as possible. But we just need to make sure we do it in a smart way, without focusing too much on any one particular concern.
Well, thanks for this perspective, Stephen. I think this judge's order is going to be very interesting to follow over the next several months. October, it needs to go in effect, and I think we've learned a lot from having you today. So if you enjoyed what you heard today, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Pass it along to friends, family, and others who might be interested. And please do consider leaving us a review if you have a chance. Thanks for joining us today, Stephen.
Thank you so much. It's a pleasure to be here always. And maybe I'll even get invited back. I don't know.
I'll consider it.